Next, we will be hearing from Dean Jamison. If you've heard of global health, you've heard of Dean Jamison. So again, it's hard for me to provide an adequate introduction, but I'll just be a brief one. We're fortunate enough to have Dr. Jamison here as a senior fellow at UCSF Global Health Sciences, but he has served in countless leadership positions at the World Bank. He edited all 3 disease control priorities editions, the most recent one having an entire volume on essential surgery, thanks in large part to his leadership. And we are so grateful to have him here today and have him part of our UCSF community. And I can't do you justice, but thank you so much for offering to speak tonight. And I give you Dean Jamison.
Well, thanks, Catherine. Certainly, having this center be created and probable evolution and growth over the next few years makes being at UCSF one more attractive element of that. You'd asked me to talk a little bit about my perception of the emergence of surgery into the consciousness of the health policy community as an essential element of our thinking about investments over the coming years and decades. And so I have reflected a little bit on some of that history, at least as I've perceived it from very much an outside perspective, consumer of literature. And there were probably 20 or 25 years ago in this environment that both Haile and Jaime have correctly characterized as a perception of it's too expensive, it doesn't do enough good, it's for around the margin. Even if it weren't, the demand on implementation would be so high that this can't be a major priority. That was the environment 20 years ago. But how has it changed? It certainly has changed enormously, I think. And there were a few early papers on experiences. The first that I'm aware of was really on cataract surgery and the possibilities of really transforming lives on a large scale, relatively inexpensively with the way it was being done. So that was a starting point, I think, in some work. Jonathan Javits and others were pioneers there. There was some work on C-section in quite resource-constrained environments. There was early work there. There was work on cervical cancer screening and appropriate surgical responses. World Bank colleague of mine, Howard Barnum, an economist and oncologist, and Greenberg, in the first round of work on disease control priorities, wrote in a very limited way on the importance of surgery for a few cancers, but I think limited to Gresham's writings there. A paper by Hook McCord, who was a Columbia surgeon in Columbia, spent a lot of time in Bangladesh and South Asia, worked a lot with Haile recently on a surgical hospital in Bangladesh where he tracked what it cost to run the hospital for a year and what they did over the course of that year and how much difference what they did probably made to the lives of people. A paper that influenced me quite a lot. But what influenced me the most, and what I think has really, as I look back at it and as I think about whatever contributions our series of analyses and disease control priorities has made, I think probably the most significant chapter was in 2006, was Haile Voss's chapter on surgery. Worked with Hook McCord, Hamdi Thind, and Richard Gossman. And that paper, that chapter, generated a lot of interest in the surgical community and anesthesia communities. And a lot of antagonism, frankly, and opposition, because it was really running uphill with respect to the intellectual climate of the time. It generated the numbers that Jaime pointed to, about a very large fraction, perhaps even 1%, of disease burden addressable by surgical intervention. And these cost effectiveness numbers that start to look good compared to some of the extraordinarily efficacious and low-cost procedures, interventions against infectious disease. And so I actually spent a lot of time asking myself the question whether I believed I did not, whether these numbers, particularly on the cost effectiveness side, whether these numbers could make any sense. And the way I ended up substantially convincing myself that this whole story was plausible, despite the fact that the costs are reasonably high by standards of anti-malaria drugs and a lot of the other interventions we're looking at, was that a lot of what the surgeons do is decisive for life or death, or it's decisive for a life that is severely crippled and maimed versus a life with a mild limp. And these are lifetime or life and death outcomes that occur in interventions that take place over a few hours. And those interventions can really be pretty expensive and still have the result look quite cost effective. What I'm just describing also sounds like a lot of our interventions against important infections. A simple infection at one point in time is decisive for life or death. And that's true for many interventions of high infection. So I ended up thinking that there was a sharply interesting comparison, analogy between infectious disease control and surgery in terms of the driving features of their economics. Obviously, they differ in important ways. So what I found to be really then one of the most important perhaps, of the pieces of work that we were doing in the Disease Control Priorities series was this chapter by Jamison and colleagues. Despite, or perhaps even partially because of the degree of controversy it created. And in Disease Control Priorities 3, we asked Rachel to just hold up that volume so you can see what damage it would do if you drop it on your foot. It's volume 1. I learned in my work on DCP 2 that I should expect it to be volume 1. I mean, for those of us that are outside the surgical medical community, it is a little peculiar, so I'm not dealing with so few people. But everything got done on time. My wife is here, but she will attest the fact that not everything gets done on time in my world. So the first chapter finished in DCP 2 was the surgery chapter. I was wondering if that might happen with DCP 3, our first volume. Kind of to suggest that it was finished. We only have one volume, so our first and only volume so far in DCP 3. I thought might be surgery. Highly, I think had no question whatsoever that would be true. So it's life among the surgeons has been interesting. This volume addresses quite a few of the issues that were raised by Heidi's earlier chapter. So it's the emergence of evolution of thinking about the placement of investments in surgery within health sector development programs. The disease burden questions were addressed and readdressed and readdressed. There was much skepticism, at least among surgeons, about this 11% number that Heidi and his colleagues have come up with. And we actually don't have a successor number because the successor number that Heidi was for essential surgery, for 44 procedures, and the 1.5 million deaths that I think can reasonably be credibly be argued could be addressed, could be averted with investment in that essential surgery. And we're still trying to sort out all these cost issues because frankly, our work in essential surgery on costs comes in quite a lot lower than you'll hear in a moment from Gavin about the exciting and important findings from the Lancet Commission on Surgery, but I don't think we've kind of sorted out yet what the costs are likely to be. And we're in sort of different places on that. I'm guessing that the commission is a bit too high here, but also it was addressing more than 44 procedures, so there's a question of comparisons of rather different things. So I think we have now a lot of answers that are better than the answers we had that these two documents this year really do help both with the intellectual agenda of helping to formulate concrete steps forward that governments might use, that development assistance agencies might use in thinking about how they allocate their resources. I think we know a lot more now as a result of these two pieces of work than we did before. Probably more important is I think there's, not more important, but similarly important, is a sense of movement that I think the creation of this center will accelerate, and I look forward to being associated with your work over the next few years. It'll be exciting, I think, and congratulations to you.